Thank you. Thank you for the opportunity that I have today to introduce you to Every Child, Every Time, our commitment to prevent and relieve pain. This is a strategic priority of the WRHA Child Health Program. Why do we need such a strategic priority? Why does pain matter in kids? Pain is an everyday experience, and pain affects everybody. We all have experienced pain with injuries, with acute diseases like the stomach flu, like appendicitis. Some of us may have experienced chronic diseases, pain and chronic diseases, and some of us may have actually experienced with pain and palliative care. And we all do know needle pokes. Kids by the age of 2 may have actually experienced up to 20 needle pokes due to vaccinations. We all do know blood tests, and some of the kids have to get medications via needles. We also would all do know procedures such as in dental care, and we know our fear of the dentist. And some of us may have experienced actually surgeries which go along with pain as well. Pain is not managed appropriately all the time. Poor controlled pain, and this is what science taught us, in preterm newborns may actually lead to impaired development of the brain, to impaired maturation of the brain. It may impair the children's later development, and it actually may lead to worse outcomes of severe illnesses in the newborns. Poorly controlled pain in childhood may influence the processing of pain in the nervous system for the rest of a lifespan. It may lead to sensitization of the body to pain, though that means actually that we may have increased pain experience with every future pain triggers. We may develop fear and avoidance of healthcare later in life. And some of the kids actually may develop chronic pain. Chronic pain affects about 20 of 100 children with or without an underlying condition. The most important sites, most frequent sites, are the head, the abdomen, and our joints and muscles. In about 5 of 100 children, pain may become a disorder, causing severe disability, keeping these kids out of school, sport, and social life. In Manitoba, we estimate that about over 14,000 children may be affected. Chronic pain is known to persist from childhood into adulthood. It is known to cause morbidity and mortality in adulthood. Just think about people with lower back pain. And it is a significant economic burden. Chronic pain costs more than cancer, heart disease, and HIV combined. It directs healthcare costs over, the direct healthcare costs are estimated with over 6 billion Canadian dollars per year. And the indirect costs due to productivity may actually be over $37 billion per year. However, we can do better. We have the knowledge, and we actually have the tools. What we want to do, what we will do, is we want to establish a program-wide policy on pain management. We will teach the staff, and we will actually empower our families and patients to know how to reduce pain. We will assess pain appropriately, and we will treat pain with evidence-based methods, which is not the case at the moment all the time. And we will evaluate clinical practice, and we will evaluate them and improve them on an ongoing process.
you very much for having me join you today. It's a real pleasure to present on behalf of the Child Health Quality Team. And I'm here representing our group, as well as the initiative that we call First Do No Harm. But I just want to explain a little bit how I got here, because that goes quite nicely in terms of the story. I'm actually a clinician scientist. I was recruited here because I'm a researcher, a clinical researcher, a clinical trial specialist. So I've been doing clinical trials and clinical studies here, and one of the trials went international, and we had a publication in the New England Journal of Medicine. But then I realized that studies only do so much. You need to be able to teach people how to do things better. So I ended up being a clinician educator. So I started running training programs here in neonatology in the specialty that I do, which is looking after premature babies or sick infants, and then in pediatrics. And also started looking after the national training program in neonatology with the Royal College. And with that, an initiative that I go and teach in China every 2 years to help them build up their capacity and provide better care in neonatology. From a completely roundabout way, and actually ties in, I'm actually an MBA. I have done an MBA here at Asper in organizational behavior and decision making, and my claim to fame is that I'm the gold medalist from our graduating class. And finally, along the same line in terms of change management, I've gone back this past year to do the Director's Educational Program course with ICP, focusing on board and organizational governance. So why do I bring that up? Because it actually ties in together what my passion is. I like to think I'm a good clinician, but I can only look after so many children. If I can teach people to do better clinical care, we can have a better outcome for more kids. So I went up being a better teacher. If we can do better research to find better ways to improve care, that might be better. So I'm a clinician scientist. But then it's not just good enough to do this. You have to make sure that the standards nationally are better. And finally, the infrastructure is better. And that's where I've been focusing on, the whole idea of infrastructure change. Why quality and patient safety? Well, there's a lot of data to say that healthcare needs improvement. And although we like to think we provide excellent healthcare, complications from what we do are now becoming a serious problem. So even in 2001, the CDC identified that in the US, there was over 700,000 healthcare-associated infections in the acute hospital, of which 75,000 died because of that during their hospitalization. And it's not just those who are sick. Half of these occurred outside of the ICU. As most recently as 2013, a group called Leapfrog, which identify healthcare issues, found that over 400,000 Americans died from preventable hospital errors. Not from their illnesses, from errors. And it is now the third leading cause of death in the US. Preventable hospital errors. Okay. I have a simple goal. I want to provide effective treatment for my patients. I want to have it at minimal cost, and I want to have it as low risk as possible. We realize that to achieve that goal, we have to fix the system. Every system is designed perfectly to get the results that it gets. But most of the problems in health and healthcare are not due to mistakes by people who are uninformed or lazy clinicians or staff, but rather can be traced to problems with the way the system in which they work on. So it's a system that tends to be causing most of the problems that are there. Okay, so system change is important. What can I show you that I am effective in system change? I've actually done quite a few. Since I've been here, we've changed dramatically the pediatric residency program to be one of the best in Canada. We've created an innovative health advocacy project for our pediatric residents, for which we've had local, national, and international acclaim. And our pediatric residents have changed 3 legislations since we've started doing this. We developed new standards for neonatal training. I run the Manitoba RSV prevention program, which is the #1 most effective program with the least amount of cost nationally. We're running a neonatal abstinence protocol because of the risks of withdraw in our newborns here. As I mentioned, I work with Fudan University in Shanghai to improve neonatal training and care across China. And I've been involved in an education system change, looking at both undergraduate and postgraduate changes as well. Now let me get back to you about system errors. For my field, I look after premature babies. Would it surprise you that in 1940s, the number one cause of blindness was not because you were born prematurely, but because you were born prematurely, you ended up in the neonatal intensive care unit. Why? Because they realized that oxygen keeps babies alive. A little bit must be good, a lot must be better. So the unrestricted use of oxygen had a consequence. They didn't realize it affected the way the blood vessels in the eyes grew. The number one cause of blindness was because you ended up in the nursery. They tried to save your life, but they went overboard and had consequence with it. A high reason why babies are deaf is because of the technology that we use in the nursery and because of the medications that we use in the nursery. One form of brain injury called kernicterus, a high incidence early on was because of the way we treated babies with our antibiotics. We started using antibiotics that predispose infants to these sort of complications. And now we're seeing, as we look after younger and younger and younger babies, we are much more effective in keeping them alive. But we're finding out that what we do and how we choose what we do has major consequences on the quality of life that they have if they survive. So it's the idea of maximizing benefit by minimizing risk. And we're not very good at doing that. Okay, I want to talk to you about our initiative. And this deals with a major problem that we have in Manitoba, which is chronic kidney disease. We, in this province, have a kidney problem. We have a huge number of adults and children with chronic kidney disease. In fact, we are one of the few provinces that has statistics on this, and people gasp at the statistics of chronic renal disease in children, about 3%. Okay, what does chronic kidney disease look like? Well, if it goes for a long period of time and your kidneys shut down, you're going to have some other means to get rid of the stuff that's in your body. That means chronic dialysis, being stuck on a machine 3 times a week, 4 times, 5 times a week. And to get yourself off the machines, renal transplant, and a whole host of lifelong problems because of the transplant and the medication you need to be on to prevent rejection. So not only does it talk about renal issues, but having chronic kidney disease puts you at risk for other problems, including hypertension and other lifestyle changes. And honestly, the quality of life if you have chronic kidney disease is not fantastic. You are undergoing a lot of care. There are a lot of things you can't do. Okay, if we can prevent kidney injury in children, not only are we going to be helping these kids now as children, but because our Manitoban population is at risk for chronic kidney disease, we're going to be helping them later on, either avoiding chronic kidney disease or improving their chronic disease that they do develop for other reasons. And this all gets to the initiative right now, which is trying to prevent acute kidney injury, AKI. So who's at risk? Well, 1/3 of non-critically ill hospital children, those who are not intensive care, develop AKI. 1 in 3. What is it? It's a sudden injury to the kidneys, impairing the kidney's ability to get rid of the toxins that we build up, to manage the electrolytes that we have in our body, and adjust the fluid that we have in the body. And when does the AKI happen? Well, it happens during the hospitalization. Sometimes a part of the reason why they came to the hospital. They're sick, and part of the body gets sick is going to be the kidneys. But that's not always how it happens. Sometimes AKI happens because it's the treatment that we give for their underlying condition. In fact, 1 in 6 acute kidney injury, 16%, it's because of the medications that we provide for their underlying disease. And the medications became toxic to the kidneys. So why does this happen? Well, again, it's a system issue. It's not maliciously done. It's because it's a complex patient with lots of things going on. And honestly, the clinical team becomes unaware of the condition, the status of the patient, the various medications that they're off and the interactions that might come to play to make the medications now toxic to the kidneys. It's difficult to keep all that in mind. Well, where is the problem? We actually used to think that AKIs in children is not a big deal. Kids can recover quite nicely. Well, we are proven wrong. In fact, up to 70% of children who've experienced an episode of acute kidney injury show signs of chronic kidney damage 6 months later. And we now know even a single episode of AKI puts you at risk for having chronic kidney disease. So medication-induced acute kidney injury is preventable. Not only is it preventable, it actually is a system issue. The system is not working well for us to prevent this. So, how should we prevent AKI? Well, in an ideal age, we should have computers, cell phones. This should all be connected. Our medical data, the condition the children's on, medication and the doses, the patient's vitals, the lab work that's there, it should all spit out and say, this person is at risk for AKI. That's the ideal. And I'm hoping in my generation we'll get to that point. But you know what? The hospital system is not set up at that point. It still takes brain power. It takes a dedicated individual to think about these issues, to recognize all the complications that's there. It takes a person to do that. So, how can we do it? Well, we have an AKI prevention program that we want to launch. And it is first, do no harm. Our first and only goal is to prevent medication-induced acute kidney injury. We do this by having a pharmacist, somebody who is knowledgeable about medication interaction, outcomes, patient issues, to monitor all medications and the dosages ordered on patients in the children's hospital. Why do we want a pharmacist? Because that person needs to know, I know, K-N-O-W for no, that's a stretch. They need to know and be able to identify and manage the medication issues. It can't be just anybody. There is a degree of knowledge that's there. And the idea is that we want to prevent harm. We do that by recognizing there is a problem before it actually happens, adjusting the doses if we need to, monitoring the level of the drugs if we have to, or even changing to the different medication if that becomes an issue. Well, why should we do this? Well, I'm not just dreaming up this program on its own. It actually exists. These things happen in the States, and really good programs, children programs, this program exists. There is dedicated individuals that do that, and it works. And it is our goal at the Children's Hospital, one of the strategic plans for the Child Health Program, for the Child Health Quality Group, to join those hospitals. But it is something we're not at that level yet. And this initiative in the US is called Solutions for Patient Safety Network. Well, what do they find? They find improved outcomes. There is a direct improvement in patient outcomes. Not only when that happens, there's a decrease in the length of hospitalization stay because we're preventing a complication, decrease in cost of hospitalized care. This actually works. So what do we think this actually costs? Well, we projected if we were to do a 1-year trial on doing this, to hire a pharmacist, it would be about $60,000. Half a year trial for the proof of concept that this worked would bring us to about $30,000. So I hope I have articulated well that we can make a substantive change in our in-hospital patients. And I hope you would support the initiative to first do no harm. Thank you.